that one thing you observe is that the warnings have gotten more dire, and the timeline before serious things happen has only gotten shorter. And that original estimates that were made, a decade or two ago, are already too optimistic. And so there is an urgency to doing things that will actually reduce greenhouse gas emissions. So this week, the County Council heard discussion for the first time on a plan for new building electrification standards. If passed, the bill is going to enact new laws by 2024. The idea is to get serious about our building energy performance standards, or BEPS as they're called for short, that passed earlier this year. In order to achieve what we wanted to do with building energy performance standards, there have to be guidelines and rules around how buildings will be built and timelines for bringing buildings into compliance. Natural gas would only be allowed in special circumstances with new construction or major renovations when they're being considered. Older technologies would be replaced by things like electric heat pumps, electric water heating equipment, and electric cooking equipment. Making this move makes financial sense. Experts say that energy prices are going to continue to rise because costs are up an average of more than 50%. Coal, natural gas, and crude oil are all costing consumers more compared to 2021. And with the passage of Bill 1322, new electric standards for new buildings will cement energy costs in place, laying a smarter framework for the future. I was proud to join CASA and the Chesapeake Climate Action Network yesterday to rally for this bill on the council steps. We appreciate their support and await the council's decisions in September. I also appreciate the second rally of support held yesterday for our rent stabilization bill. I'm glad Matt Losek can join us today and talk a little bit about the struggles that people have whose rents are now going through the ceiling. 40% of our county are renters. We have tens of thousands of people who are earning less than $50,000 a year who are already spending 50 and 60% of their income on housing. This is an extraordinarily large number of people. And to put it in perspective for folks, if you're making, say, $50,000, the most you're supposed to pay in rent is 30% of your income. That's not the benchmark, that is the high mark. And that works out to about $15,000 a year, which is a little over $1,250 a month. We have our residents, many of our residents are spending 50 to 60% of their income. And we have tenants who are paying $1,500, $1,600, $1,800 to live in the apartments in the county. And if you were paying $1,500 and you get a 20% rent increase, that's a $300 rent increase. If you're paying $1,600, it's a $320 rent increase. If you're paying $1,800 a month, that's a $360 increase. These are increases that our renters are simply not going to be able to afford. I understand that there's some philosophical objections to rent stabilization, but I have philosophical objections to things that will make people homeless and make people impossible to live in our community. And I really do worry it's not just an issue for tenants. Frankly, it's going to be an issue for the workforce in the county if we cannot find ways for people to be able to afford to continue to live here. This is a significant population, and they can't afford some of these proposed increases. Before I talk more about the legislation, I just want to announce that we've reopened our portal for more COVID-related rent relief. Again, that money is there for COVID-related rent relief. In other words, you have to have lost your job or had your hours reduced because of COVID. It's been almost a month since the window closed on the latest round of rental relief grant money available to those 2 months or more behind in their rent because of a COVID-19 related reason. As expected, there was a rush to get applications in ahead of the June deadline, with 1,157 applications being delivered just under the deadline. In just 45 days, more than 4,000 applicants sought assistance. We're still processing these applications, but you should know they're not being done on a first come, first served basis. We're still assessing how the best to spend the $25 million available in aid. Sadly, we're seeing some people who didn't apply coming to us with eviction notices, and we're trying to help them as well as we can in part of doing this. But now back to the rent stabilization efforts. This week, the council heard testimony from more than a dozen speakers who talked about the challenges they face if the rent goes up 20%, as some landlords or property managers have indicated they would. Other renters are finding out that after years of living in the same place, their leases will not be renewed. If limits are not put in place, it threatens to destabilize families. My proposal would set limits for rent increases at 4.4% for 6 months. That would give us time to work on a more permanent solution, a rent stabilization bill that addresses the greatest need and would not impact on the construction of new housing. And I believe such a bill can be constructed. I know the District of Columbia has a rent stabilization bill that has some model provisions in it we'd like to look at. We have to make sure that people living in buildings most vulnerable for redevelopment are protected, and people making the least amount of money can't be priced out of their homes. The earliest the council could act on this proposal now is September, when they return from break, and people are already getting these rent increase notices. Our region already deals with high housing costs. Asking people to dig deeper in their own pockets for a necessity is something we should try to prevent, particularly since they don't have anything, they're not going to be able to dig anything out of their pockets. For many of these families, digging in and finding another $300 for rent would mean not putting food on the table. It is that stark a reality. And I think we all have to think about this and maybe check our philosophy at the door and focus on how do we prevent a human catastrophe from happening here. I'm now going to turn it over to Matt Losek, the Executive Director for the Montgomery County Renters Alliance, for his perspective on where we stand on rent prices right now. So Matt, I'll turn this over to you.
Thank you, County Executive Elrich, and thank you for the opportunity to give our perspective at this media briefing. We are going to see, because the council did not act, the forced migration of working families and low-income families from Montgomery County if the council does not enact this bill. Already, we've seen hundreds, if not thousands, of rent increases in the double digits, some as high as 50 and 90%. People are not going to be able to stay in their homes at these kinds of increases. As the county executive pointed out, it's not just low-income families, it's across the economic spectrum. Renters cannot pay these kinds of rent increases over the long haul. Some may be able to eke it out for a year at 10 or 20% rent increase, but they're not going to be able to stay for the long term. So what does this mean? What does housing instability mean? What is the cost? Well, not only are we going to see rising healthcare costs and safety net costs and increased homelessness, but we're also going to see increased spikes in crime. We're going to see a lack of academic achievement by children who have to move from school to school. These are critical social welfare aspects that we need to look at if we don't act. Right now, most renewals take place in the late spring and summer. When the earlier emergency rent cap bill expired May 15th, we saw an avalanche of renewals taking place across the county because that's when people move, that's when people move in. So renewals, the bulk of them are occurring right now. But because the council did not act to pass this legislation, which was very balanced and very reasonable, we saw a wild west of rent increases. So because rent renewals have to be 90 days prospective, all of those rent increases needed to be protected by the rent legislation bill, or they're going to go into effect permanently. So we're going to see a large number of people who are going to be forced out of their homes because of these rent increases, no matter what happens in September. So unfortunately, we are concerned that the council really neglected a huge number of people in Montgomery County, and it was a dereliction of duty. We do believe that landlords should have a reasonable return on their investment. We have no problem with a landlord making a reasonable profit. We have no problem with a landlord being responsible and raising rents to keep up with their overhead. But that's not what we're seeing. The double-digit rent increases are not about keeping up with inflation and overhead. They're about profit gouging. What we're seeing is that the market, the high demand market in Montgomery County and our region in general, and in other parts of the country, is so high that the market allows for landlords, irresponsible landlords, to raise rents astronomically, skyrocketing rents are a profit gouge. They are not something about landlords trying to keep up with expenses. We heard last night from the Small Landlord Association, portraying the issue out there as mom and pop landlords struggling to keep up. But we have to realize that rent includes profit. It includes obviously maintenance and overhead expenses from a landlord, but the initial rent should include, by any landlord who knows how to do basic math, should include a margin of profit. Then we expect them to keep up with expenses. The county executive's bill at 4.4% is 4 points higher than the CPI provided by the voluntary rent increase guidelines, which is now 0.4%. It was a balanced bill with an intention to allow landlords to keep up with these rising inflation expenses, but also not allowing gouging to take place, which is what we're seeing everywhere. So we are deeply concerned, as again, we are concerned that there's going to be a forced migration of working families and low-income families. We also know that the council and the county executive's office have put a high emphasis on advancing racial equity. We know that the impacts of these kinds of double-digit increases will have the greatest impact on people of color, widening our racial divide and increasing more stress and strife in our communities. Well, stable, affordable housing means better community welfare, community prosperity, community health. And unfortunately, so far, the council has failed to act on that and failed to act on its commitment to the people of Montgomery County. We hope that'll change. We urge it to change as soon as possible. Otherwise, I don't know where people are going to go.
Thank you, Mr.
Thank you, Matt. Thank you, Matt, for your comments. I just want to double down on, the school impact. If we start looking at higher mobility rates, if people get into the routine of having to move every year in order to find the lowest rent they can afford, this really has an impact on education. It has an impact on school. And it's not something that we can just brush aside and say it's not attached to the rent issue. It's pretty closely attached to the rent issue. So I do think, as a former teacher, that we need to be aware of what the impacts are of our policies. And I know that some of the council members feel that they had an agreement that the last time they raised this, they extended the time frame. It was going to be the last time they extended the time frame. And I would just ask them to consider that the circumstances changed. None of us were looking at hyperinflation. Inflation had been relatively tame for a very long period of time. And suddenly that has changed, and it's having an immediate impact, a sudden impact on the tenants as well. And so whatever decision we made in the context of the conditions that existed when the last extension was made, those aren't the conditions today. And we should be willing to rethink what we did based on the changing circumstances. So I hope the council can think about a way to deal with this and talk about some ways to address what some of their concerns might be, to make sure that we provide the most protection to the people who are most vulnerable. So meanwhile, back at the COVID update.
Mr. County Executive, allow me to interrupt you for a second. We would like to open the Q&A portion of the presentation regarding the legislation and renters issues. All other topics, we'll cover them after the COVID-19 update. So members of the media, does anybody have any questions for the County Executive and or Mr. Lozak regarding the legislation and or renters issues?
Yeah, Ali Schweitzer with WAMU. I have a question for the executive.
Thank you, Ali. Good afternoon. Thank you.
I was just speaking this morning with Council President Gabe Albornoz, and he was telling me his side of things when it came to the rent stabilization bill. And his answers to my questions were, they kind of hewed closely to political issues, but I want you to respond to one thing he said. He said that with regard to the expedited bill, he said the county executive, quote, announced this extension within the context of a political debate, not having spoken to the council or anyone really. He seemed to be shooting from the hip, end quote. So it sounds like he's saying that the rent, that you were aware that there was not enough support on the council for this to pass, but introduced it anyway. Could you respond to that?
It's kind of a bizarre comment. I've been a long supporter of this and questioned whether or not it was going to be wise to end any number of things, including our own rent support programs, because the need is still far too great out there. You know, for example, in our own rent support programs, because the limited amount of money we've had, and we've had an enormous amount of money, and yet it's limited. You know, we've been basically held to helping people who were in arrears whose incomes were below 50% of area median income. We haven't even scratched all the folks who haven't been able to pay rent but have higher incomes. I didn't say this in the context of a political thing. I've been talking about this problem and well aware of it as we saw the inflation rates rising. I can't help that this was also the political season. That's just the way it is. But this doesn't make it any less important. And putting legislation forward, I mean, if the rule was the council's not going to discuss anything unless there are already 5 votes to support it, that's not much of a democracy. I mean, we ought to have a discussion about it. If at the end of the day, people don't think it's worth doing, then they can vote not to do it. I don't have any ability to compel this. I can't do this by executive order. But if the rule is going to be that no one proposes anything unless there are 5 votes, you're going to stifle a whole lot of discussion about a whole range of things if that becomes the norm for how you make policy. Sometimes, and it happened when I was on the council, ideas that didn't have the votes in the beginning wound up getting the votes at the end. And if they hadn't been pushed, there never would have been an end. So I just reject that form of criticism. If he doesn't support it, he doesn't support it. He's entitled to his position.
Thank you, Ali. I believe Kate Ryan, WTOP, has a quick question regarding the rental issue. Good afternoon, Kate.
Hey, yes, thank you very much. And Mr. Losak, this is one for you. I have heard from renters who say they're paying $100, $200, up to $600 more a month in rent in some cases. But you mentioned some people paying 90% more. Can you elaborate on that? And are most of the increases at these larger building managed buildings, or are they the mom and pops that we hear about?
We've been collaborating with the Office of Landlord and Tenant Affairs about these rent increase complaints. The Renters Alliance received a increase from a tenant of 53%. We held a renter town hall a few weeks ago where we had the Office of Landlord and Tenant Affairs manager on, who said she received 2 increases, one at 70% and one at 90%, which led to about 5 minutes of silence and head shaking. We couldn't believe it, but we know that it's happening out there. I also want to emphasize, since we have heard that some of these increases from those who oppose the rent stabilization bill are anecdotal. They're not. They're the tip of the iceberg. If you receive a rent increase in a large corporate building of 50% or 20% or 10%, all of which are not sustainable, we're confident that it's not singled out to one tenant, but it's actually probably happening systemically throughout the building. This is a regional and national problem, and only responsible landlords are keeping rents down so they can keep up with their expenses. But there is a Wild West attitude that increasing rents and making as much profit as possible is okay.
I think you've hinted at this answer too, but I'm going to ask. We have heard from AOBA that says, look, there's a lot of deferred maintenance because of COVID. There are instances where some of these landlords got hit with big losses because people simply couldn't pay and are still unable to pay. How do you respond to those arguments?
Well, first of all, if it's real, obviously we're sympathetic. I think the landlords who are struggling to maintain their expenses have our sympathy, and we understand, but they're not losing their homes. The government, federal government, and the state government has pumped in hundreds of millions of dollars in rent relief. That does not go into renters' pockets. That goes into landlords' pockets. So there's a balance here. Landlords have to step up. Some of them have taken some hit on their profits and maintenance issues, but also tenants too have struggled immensely to maintain their jobs. Many of them lost their jobs, especially working families and low-income families. So there's a balance in the pain that we've all experienced. But I would question any landlord who says that they can't, we've heard that the landlord industry is suffering tremendously, and yet I have not seen any landlord company move out of town or shut down. All of the major properties in Montgomery County are still operating. Nobody has gone bankrupt that I know of. So we understand that there's a struggle out there. I believe, again, that this bill was a balanced bill intended to provide landlords with an extra increase that beyond the voluntary rent increase guidelines to keep up with some of these inflationary issues. But it was also intended to provide predictable, reasonable increase for renters who are struggling. We have to maintain this balance and eliminate this notion that housing is the same thing as beer and cigarettes and fancy sneakers. It is central to community welfare, prosperity, and health. And if we don't see that, we're going to all pay for costs down the line.
Thank you.
Thank you, Kate. Members of the media, any more questions regarding rental issues? Okay, thank you very much, Mr. Losak, for joining us today. We let you go now. Have a great afternoon. Thank you.
Thank you.
Mr. County Executive, COVID update.
So meanwhile, back at COVID. Earlier this week, Montgomery County crossed the key parameter, taking Montgomery County community level status from medium to high. Our case counts continue to hover around 250 cases per 100,000 residents, and the percent of staffed inpatient beds devoted to COVID patients is now at about 10%, and the hospital's admission rate is 12.7 people per 100,000 people. Health experts say it's because the latest strain of the disease is easy to pass from person to person, even among the vaccinated and the boosted. The good news is that those with shots, in the majority of cases, are kept from having to deal with serious bouts of the disease. The bad news is that many people let their guard down and are not taking seriously how devastating COVID can still be in some cases, or the effects of long COVID. In March, we were down to less than 50 cases per 100,000 residents. So this is a big increase since March. Both hospitalization figures were less than half of what they are today, and we have to be ready to react properly to COVID symptoms. If you feel sick and get tested, if you're exposed to someone who tests positive, isolate until you can actually test yourself. And if you test positive, prepare for at least 5 days of isolation. And I'll add, you should really not go out of isolation until at least you've taken a negative test. You shouldn't assume that just because you're 5 days in, that you're no longer capable of spreading it. There are too many cases out there, including some I know about, where that assumption proved to be wrong. If you're taking a bus or going somewhere indoors, have a well-fitting mask ready to put on, regardless of your vaccination status. And you can pick up free N95 masks at any library and some community centers across Montgomery County. And of course, the best way to protect yourself is to stay up to date on your vaccines and boosters. And just because they have an exceptionally high vaccination and booster rate in Montgomery County doesn't mean we want to test our healthcare system again and put lives in danger. You know, the big risk for us right now is making sure we don't overcrowd the hospitals. And so people getting, particularly people who aren't vaccinated or, you know, maybe only had one shot, getting more severe cases of COVID can really put a load on the hospital system, and that's what we have to avoid. We also have a new public health threat to prepare and respond to in the Mpx. This week, we learned about the first 2 children nationally, one in DC, to catch the virus. And so with that, let me welcome Dr. James Bridgers to take us deeper into this week's Pulse Report, and Kimberly Townsend, Senior Administrator for Communicable Diseases and Epidemiology, to talk about our Mpx response, which we've been preparing for since May.
Thank you, Mr. County Executive. Happy to join you again on your weekly press conference. Let me just share some additional data to the information regarding our ongoing COVID response. And let me just stop the subtitles here. And so as you indicated, we do have yet another variant. It's BA.5, that's the predominant variant in this region. We've been tracking it since it was first sequenced over internationally. We spoke about this on many of your weekly conferences. And so we continue to track that. But there's yet another variant of concern out there, the BA.2.75, which is a variant of concern that the Centers for Disease Control and Prevention is tracking now. And so, as you indicated before, after Omicron, we've seen these wavelets and we've seen these increases, and we've continued to implement those layered preventative measures. And I had some additional data points regarding that as well. But COVID is still here, as you continuously advise the media and the public, and we should continue to plan for it as we continue to plan for any virus or any illness. And mild COVID is still COVID. If individuals are sick, if they experience congestion, runny nose, a fever, and they test positive, they should isolate according to CDC's definition of their isolation and quarantine, and test often. And so similarly, we continue to track all the variants, both nationally and internationally, and we continue to look at those data points and trends as we often see increases in elevation in cases in the Northeast region, and then the Western region of the country, and then the Mid-East region, 3, as we continue to monitor. And all of those data points are consistently trending according to that average, but the cases still exist. And we know that there are unreported cases, as you indicated, in the community, either rapid tests or individuals feel sick and they just continue to isolate, but COVID is still in the community. And so our numbers speak as such, and we continue to implement those measures and provide educations and make our COVID information portal more robust. We have yet another tool and resources in place where we will indicate those high levels, and we will have those CDC layer preventative measures regarding community transmission levels, low, medium, and high. And we are in high in category now because of the number of cases. Now, should we fall below that 200 cases per 100,000 threshold, we will change our narrative information accordingly. But this is an additive process. It's not that we're in high and then we go back to low. It's not the off ramp and on ramp we saw early on with Omicron. Again, COVID is here, and we need to continue to shape our behavior accordingly when our community levels change from low, medium to high. And this is just some additional narrative regarding what to do, wear well-fitted masks. If you're immunocompromised, of course, consult your primary care physician. And if you're in close contacts, the CDC further recommends that you consider setting specific recommendations, preventative strategies, which you have asked your public health team to do. We have ongoing conversations with our congregate spaces, our correctional facilities, our homeless shelters, our assisted living facilities to assess the level of infection rates in those areas, and may require more preventative measures such as more frequency in testing, more monitoring, more surveillance screening and access, as we saw early on. And so we continue to look at the data, not only those reinfection rates, those post-infection rates, but where those data points lie. We continue to see that many of those infection points come in the age group of those who are 18 to 64. And we continue to look at those reinfection rates as we have conversations with our great community partners and our community hospitals based on the numbers when we look at those thresholds to assess whether or not there are occupational bed challenges, whether or not there are respiratory therapist challenges, whether or not there are challenges with their nursing staff as well. Now, although our hospitalization of positive cases indicate that we have 131, it may be slightly higher than that, but we have 60 patients who are currently hospitalized at our alternative care site, which includes our monoclonal antibody treatment site. And this is a regional snapshot based on the Montgomery County and Prince George's Hospital. Again, many of these individuals who present in our emergency department may come in with a fever, or they may not know that they are positive, and they test positive as a result of being assessed and triaged for other illnesses. As you indicated, Mr. County Executive, our death rates aren't as high as they were back in January because we have a high vaccination rate, I presume, but there's still individuals who are hospitalized and who continue to die because they are unvaccinated. And so we've worked very aggressively, proactively with our communication teams to have ongoing vaccination clinics throughout the summer. We know fall is coming. We have other measures and resources and tools that I will speak to in a minute, but our vaccination rate is lower than we would want it to be in public health, and we need to get our vaccination rate. So those individuals, we have a very proactive campaign to not only get individuals vaccinated with their primary series, but get boosted if and when they become eligible. Our test sites are slightly lower than in previous weeks. And so we continue to maintain those fixed sites. Our positivity rate is higher than what the state is indicating, as far as around 8%. But we know that most of the results that are coming back through our labs and our sequence, we know that those individual positivity rates. So there's community level transmission that is high previously, as we articulated prior to transitioning to CDC's community level monitor. But we use both community transmission rates and community levels to assess the severity and transmission rate in our county. And so we've administered just over 2,000 tests and about 1,500 doses last week. And we continue to encourage our great countyans to come and get vaccinated and or tested if they travel to other areas that may have medium or high community levels. If they travel internationally or to other points of interest, then they get tested. And if they test positive, then they should isolate and stay home. We've done a great job in administering our pediatric doses and working with our Montgomery County Public School partners to ensure equity and access. As you see, we have administered almost 9,000 first doses to about 50,000 under 5 children. And so that will strengthen our ability to have our children return to school and be in a classroom environment, unlike last fall when there were challenges regarding guidance and maskings. We know that most of the guidance is set according to vaccination status thus far. Now that is subject to change, but right now we're on a good track, and we continue to have vaccination clinics in the evening so that parents can get not only themselves vaccinated, but their children vaccinated as well. And we have them on the weekend as well. Here's a snapshot of where those pediatric vaccines have been provided. Unlike the 5 to 11-year-old vaccines, most of those doses were administered in the county through the public health system. But now we have our physician offices, our urgent care, our hospitals, and other community partners administering those doses to increase our capacity and capability to get those who are still unvaccinated vaccinated. This is just a snapshot of some of those upcoming county and toddler vaccine clinics that we have starting this week and going into next week, which will be posted later on in the week. Lastly, a couple of final points. We know that Novavax received authorization regarding its use. We haven't seen or received Novavax in the county. We will have that protein-based vaccine available. It is not and has not been approved as a booster. So individuals who will come in, they will either get the Pfizer, Moderna, or the Novavax vaccine as a primary series and not a booster. There are other places, and I've listed them here for availability for the public to have access to the Novavax vaccine once it's being distributed in the county. And then lastly, we have a meeting next week. I've been talking about the resources coming in, thinking of the fall and our capability to assess wastewater surveillance. And we have a kickoff meeting to look at the scope and work of doing that. That will be a nice piece to look at community level transmissions to see where those pockets are in those areas using census data and zip code data to provide education and have an early warning system as we may anticipate fall spikes. Now, lastly, before turning it over to Ms. Townsend, who is our Senior Administrator for Communicable Disease and Epidemiology, who will give us an update on our Mpx surveillance. In our efforts to destigmatize monkeypox, we have repeatedly, and you will hear us repeatedly use Mpx, because we know that Mpx can be transmitted through other modalities, although it principally has affected at-risk individuals. But we will continuously, in an effort to destigmatize monkeypox, use Mpx surveillance. I'll stop there and turn it over to Ms. Townsend, who will give you an update on our Mpx strategy. As Mr. Elrich indicated, we've been monitoring this and providing updates regarding this now World Health Public Challenge since May.
Thank you, Dr. Bridgers. Thank you, Mr. County Executive. Just like to mention about surveillance, that currently the Maryland Department of Health is maintaining records of cases and investigations across the state of Maryland. Montgomery County Department of Health and Human Services is assisting in identification of local and contacts for further follow-up, and where applicable, we are providing vaccination or treatment. We have seen an increase in cases nationwide. In the state of Maryland, as of yesterday, there are 91 cases of Mpx, and this is an increase of 20 cases as compared to last week. As Dr. Bridgers mentioned and Mr. County Executive mentioned, back in May, Montgomery County sent out a public health advisory regarding Mpx. We started working on our plan on how to address this issue, specifically looking at ways that we can increase capacity so that we're able to provide screening assessments as well as vaccination to community members. In doing so, we've requested some local funds to help us expand capacity by adding an additional nurse practitioner and registered nurse to our HIV STI programs. We're also working collaboratively and communicating regularly with our partners at the Maryland Department of Health, as well as our community providers, our physicians and practitioners. In terms of CDC overview of Mpx transmission, we know that anyone, regardless of gender identity or sexual orientation, can catch monkeypox. We know that symptoms generally last 2 to 4 weeks, and that people without symptoms cannot spread monkeypox to others. We also know that there is post-exposure vaccination, and it is recommended for cases that are quickly identified. Transmission is most likely to occur as a result of direct contact with lesions, even if they're crusted or scabbed over, and can occur through respiratory droplets in fomites, for example, towels or linen, things like that that are shared. Even though Mpx is not considered a sexually transmitted infection, Mpx can be spread during intimate physical contact between people. Again, anyone can get Mpx if they have close contact with someone who does have the virus. A few words about Mpx vaccinations. Montgomery County Public Health has received a very limited amount of vaccines. We are hoping, or we're expecting to expand in the upcoming weeks and months in terms of what we will receive from the Maryland Department of Health. We're working with the Maryland Department of Health to ensure that vaccine is available to those at highest risk for exposure. Therefore, currently vaccination is limited to known contacts who are identified by public health via case investigation, contact tracing, and risk exposure assessment. We are also providing vaccination to those who are presumed contacts and meet the following criteria. Those that have had a known sexual partner in the past 14 days that were diagnosed with Mpx, and those who have had multiple sexual partners in the past 14 days in an area with known Mpx. To date, we have administered 108 vaccines at the Dennis Avenue Health Center, and this was done through our HIV, STI, and disease control programs. We also have scheduled approximately 50 appointments, which means we have used or accounted for at least half or just over half of the vaccine that we have been allocated from the Maryland Department of Health. DHHS is supporting the Maryland Department of Health on Mpx cases and exposures by working with primary care providers to help identify cases and coordinate testing and referrals. We are identifying close contacts who may be eligible for post-exposure prophylaxis, otherwise known as PEP, on a case-by-case basis. We regularly consult with Maryland Department of Health for treatment and administration of PEP, and we continue to advise affected individuals regarding isolation, monitoring their symptoms, and advising as to when isolation can be ended. We also are assisting with interjurisdictional contacts, meaning if contacts that are exposed to Mpx in other jurisdictions outside of Montgomery County, we reach out to them with follow-up in order to offer vaccine as appropriate. In terms of community outreach for Mpx, we are currently working on an online survey, very similar to the one that we used for COVID-19 response. The purpose of the survey is to initially identify those that are interested in receiving the Mpx vaccine to protect them. It will also help us identify those that are in the high risk category so that we can outreach to them. We're also working on risk update communications and screening through the Dennis Avenue Health Center sexual health programs. We're working on healthcare provider communications and updating our HHS Mpx webpage to include fact sheets and frequently asked questions. That's primarily where we are in our planning for our Mpx response, and I'm happy to answer any questions.
Thank you, Mr. Townsend and Dr. Bridgers. Reporters, we're going to open it up right now for the Q&A portion of the presentation. Do use the chat to request to ask your questions. And you're up first, Kate Ryan, WTOP. Good afternoon again, Kate.
Thank you very much. I appreciate it. I want some clarification, if I may, on what pushed us up to the high mark now. For example, I look back at July 16th and we had 264 cases per 100,000, higher than what we have now. And our hospitalization then was 8.2. Now we have 232 cases per 100,000, but our hospitalization is over 10 at 13.1. Is the hospitalization number what's driving that designation too high?
Good afternoon, Kate. And yes, it is the hospitalization numbers. According to CDC's definition, when you look at community levels, be it the case rates or the hospitalization rates, when one indicator or measure goes into a higher category, you use the higher category. So you will see, even as the numbers plateau or decline based on the number of cases that we have, if our hospitalization rates are higher, then we will use that indicator, meaning that there's some stressor on our hospital system, and we will continue to monitor those hospital systems, similar to when we use the test rate, case rate, and test positivity. When we had a high test positivity rate and a lower case rate, we used the test positivity as an indicator or measure regarding our community transmission rates.
Okay, quick follow-up on that. I see the hospitalization figures include Prince George's and other counties. Is that new? And then lastly, the recommendation on masks. The county has never stopped recommending that people wear masks. Am I correct?
So, Kate, again, great question. So let me take the first part of your question. No, it's not new. It's an aggregate total of the Montgomery County Prince George's hospital systems. And so we've used that number. Now, we have the numbers based on the ICU and acute care beds for those 6 Montgomery County hospitals, and we monitor those daily as part of our emergency preparedness. and response, which includes the number of individuals that present at our emergency departments. And so we use those numbers to represent, but it is, it is an indication of the hospitalization rate. In addition to the number of acute care patients that may receive care at our Washington and Venice Tacoma Park station, which has traditionally been our monoclonal antibody treatment. So it may be 70 across the 6 hospitals, and it may be 60 in the acute system, which gives us the number. So that's how we've been managing and monitoring the data. And then the mask recommendation has never really gone away. In those cases where we have lower or medium transmission rates, there are protective measures, individual and congregate measures as defined by the CDC that we present and we indicate to the general public. We know that when there are higher cases, there are more layer preventative measures that we need to do. In addition to mask wearing, washing hands for more than 20 seconds, maintaining well-ventilated spaces, wearing masks in congregate spaces. If you are immunocompromised, wear a well-fitted mask. Check with your primary care physician regarding any other layer preventative measures. So it hasn't gone away and it won't go away. It's just in those times, and you mentioned some metrics. So back in May, we were close to that 200 level threshold and it decreased. On July 8th, we were closer to that 200 level threshold, and it increased, went down, and we were seeing wavelets. We've had 5 subvariants of the Omicron variant, 5 sublineages. And so this variant is highly transmissible. So folks may present with fever, they may enter the hospital with other illnesses and test positive and be treated and released, but we still continue to track those metrics because it may have some indication or some stress on the system that we realized during the Omicron variant spike.
Thank you very much. I'll defer to other reporters.
Thank you, Kate. Good afternoon, Kevin Lewis, ABC7 News.
Hi, good afternoon to you. County Executive Elrich, I had questions on 2 separate topics. The first, multiple police sources are telling me there's an active internal investigation ongoing into an officer amid allegations that he was stealing narcotics from the evidence room. Have you heard anything about this?
No, they haven't raised that with me.
Is that something that I reached out to numerous law enforcement sources yesterday and everyone said that is the rumor going through the department right now. And everyone in the inner circle has been told they need to sign non-disclosure agreements. But that what I've been told is that the department is trying to handle this outside of court under rehab drug addiction as opposed to criminal prosecution.
So this is all interesting things I will follow up on. This is all new to me.
Okay.
And so I don't know enough about it to comment whether it's appropriate for rehabilitation or whether it's a serious crime.
Okay. I've heard everything from this was a one-time incident to that this was an ongoing situation. But anyhow, I just wanted to reach out to you. Second to that, on a totally unrelated matter, I received some information that people within your office are at the ballot count in Germantown, and questions as to if those county employees were on the clock or if they were taking personal time in doing that work.
They're in personal time.
Okay. And the names that were provided to me were Debbie Spielberg and Dale Tibbetts. So those are individuals that are using personal time.
Yep.
Is there any?
Everybody knows the rule pretty clearly.
What is the rule exactly on that?
You can't do anything political on work time, period. So if you're there, obviously you're monitoring a ballot and you're doing it for a campaign, you cannot be on the clock for the government, period.
Are they are they re-election staffers, or are they just doing this on a volunteer basis?
It's a volunteer basis. You know, last time we had people, you know, we had folks who monitored the counts, and they're experienced, and so they're monitoring counts, but it's totally normal.
Okay, cool. And on the first issue, I'll circle back up with you guys on that as I try and get more information myself.
You know how to find me, so if you shoot me a note with whatever details you have, it'll help me dig into it.
Okay.
Like, you know, it may just, if it's a personnel issue and strictly a personnel issue, then obviously, you know, that those never get discussed. But if it crosses to something not personnel, that's a different world.
Okay. All right. Thank you.
Thank you, Kevin. Up next, Steve Bonnell, Bethesda Beat. Good afternoon, Steve.
Afternoon. County Executive, you made some comments in other media outlets about the count and it not being up to par. I'll use that phrase. Do you want to elaborate on that?
Look, I mean, the Board of Elections, for one thing, have suffered from lack of funding at the state level. You know, this went through discussions at the legislature, and the governor has not been willing to adequately fund the Board of Elections. You know, that said, you know, we knew the really bad decision the governor made, which has created a lot of the problem by not allowing people to count the ballots when they arrived, because he vetoed a bill that would have allowed it. And that's obviously had an impact on their ability to handle this. But I don't feel that they were well prepared and that they've handled it in the best possible way, because they did know, as bad as it is, what the governor's decision was and what it was going to mean. And I'm not the only one who feels this is not the best performance ever.
Do you feel then fundamentally this is a staffing issue?
I think it's a staffing issue, but I also think it's a preparation issue. Like I said, they knew some of these things, or that they were going to have to deal with some of these problems. And I'm not going to get anything more than that. I'm just disappointed that it's been as difficult as it is.
You're not questioning the count, though.
No, not questioning anything about the integrity of the count.
Okay. And do you have any comment? David Blair's been on vacation. Do you care about that at all?
No, why do I care? He goes on vacation all the time. He's a billionaire. What difference does it make what he does? Doesn't relate to my life.
Okay. Thank you, sir.
Thank you so much, Steve. Up next is Heather Curtis, WMAL. Good afternoon, Heather.
Good afternoon. Thanks so much for taking our questions as always. County Executive, I'm wondering, in light of the increase in cases, is there any talk of reinstating an indoor mask mandate?
I would leave that talk to begin with folks in the health department. I think, what's changed from the beginning is cases were, very heavily linked with bad outcomes. And we were, like everybody else in the world, trying to tamp down the death rates and all that. We're in a situation now where, if you're vaccinated, you may get a case, but you'll probably never see a hospital unless you go there mistakenly for emergency care and then wind up being sent home because you don't belong in a hospital. So the big focus has been on hospitalizations and making sure that, and Dr. Bridges can correct me if I'm wrong, but I think the goal is to make sure that we don't outrun the space with people in the hospital so that the beds aren't available. And so that's determined, I think, now in terms of where you go and trying to tamp down the infections. If people aren't dying and it's relatively mild, or frankly, if the people who are dying are people who refuse to get vaccinated, I can't do anything about that. But for other purposes, the hospitalization rate really is the arbiter of how I think we're going to handle things. And Dr. Bridges may want to.
Sure. Thank you, Mr. County Executive. And Heather, there is no public health recommendation on the horizon to reinstate a mask mandate. We have fashioned our education, public health education, around the efficacy of mask wearing. As I indicated in the presentation, we will have visual graphics to indicate where we are in those high community levels. We continue to monitor those community transmission rates prior to us having those infamous on-ramps and off-ramps back in the late fall and winter, we didn't have as many folks vaccinated. We didn't have a 5 to 11 vaccine available, and we didn't have an under 5 vaccine available. And many of the guidance and policies that I'm reading now are predicated on increased vaccination. We know that vaccinations and the vaccines are effective. We don't see the number of deaths as we have seen in the past during pre-Omicron and Omicron spike as we began to vaccinate more individuals. And lastly, the burden on the hospital system as we experienced during the Omicron spike was the reason why the CDC changed their recommendations from community transmissions to community levels, because it impacted the healthcare system with not so much as having beds occupied and staffed, but those individuals, those healthcare professionals who were able to respond to those individuals who were positive with COVID, such as respiratory therapists, occupational therapists, dietitians, primary care physicians, infectious disease docs, nurses, and even admin staff. So these are the conversations that we've had with our hospitals regarding the stress on them. And we continue to have these conversations on an ongoing basis so that we can assess. So even when we get close to those thresholds as defined by the CDC, we can act accordingly and put safeguards and preventative measures in place.
Is there a rate of hospitalization? If the hospitals start looking more crowded, if there's more of a strain, would there be consideration of another indoor mask mandate? Or at this point, does it seem like we may be okay with hospitalizations?
Well, we're never okay when there's a high level of hospitalization, but there are thresholds that the CDC defines, so a range from 200 to 500, and we continue to assess that those threshold metrics and work with our teams and our hospitals regarding that. But currently, the way forward is for individuals to get vaccinated, to get their primary series, to get boosted when they're eligible, and wear masks and consult their primary care physicians if they are immunocompromised or have other chronic illnesses that may cause them to visit the hospital.
Thank you. And if I may, one more for the county executive. It seems like you're a little bit frustrated that the voting process is taking so long due to the state law around mail-in ballots. What's going through your head as you wait for the results, given that it is so close and you're only 134 votes behind David Blair?
Look, the same thing was going through my head the night of the election. There are a lot of votes to count, and you know, if you're going to jump up and down in any one day's results, you're going to do a lot of futile jumping up and down. So you just wait till it gets done. So I'm waiting till it gets done.
Thank you.
Thank you so much, Heather. Mr. County Executive, you do have a hard stop at 1:45 this afternoon. So let's move forward now with Darcy Spencer from NBC4. Good afternoon, Darcy.
Good afternoon. Pretty much what I was going to ask has already been asked, but just a couple quick follow-ups. As far as the masking mandate, I don't know if Dr. Bridgers could answer the question regarding schools in the fall, or if we're looking at where we are today or worse, what are you looking at as far as masking in schools? And the other is, do we have a number of monkeypox cases for Montgomery County, or have there been any cases reported in the county? Thank you.
So great question, Darcy. And yes, I can answer the first part of the question and can answer the second part, but I will leave it up to Ms. Townsend to give you those numbers, because her team tracks those not only with the post exposure, but those individuals who we have identified at risk. There is no decision regarding indoor mask mandate. The push, Darcy, really is to get our school-age children vaccinated, because we know that the guidance that's set forth, and we're reviewing any additional updates to the guidance, will, to the best approximation, be shaped according to vaccination rates, not only for students, but teachers and staff. And then there's a separate course for a recommendation for an indoor mask mandate. Ours would come through the Board of Health. Council sitting as a Board of Health, and the school system will send it to their Board of Education to vote on. So there's no indication right now we're moving in that direction. The big push is to get our children and our counties vaccinated and boosted accordingly so that they can have the best immune response to any of the variants on the horizon or any of the sublineages that are in the community. Now I'll ask Ms. Townsend to share with you the updates regarding the numbers that we have. I think she gave them out earlier, but she can repeat them.
So thank you for your question, Darcy. So just as I mentioned earlier, for surveillance, currently the Maryland Department of Health is maintaining all records and surveillance for cases and investigations across all Maryland jurisdictions. There are, as of yesterday, 91 cases in the state of Maryland. However, in terms of specific numbers to our county numbers, we have not received that information. That has not been shared with us to date.
Okay, so it's not that you don't have any, you just don't know if you do or not.
Those numbers haven't been shared with us yet. The way that we're supporting the Maryland Department of Health at this time is we are following up with contacts that are referred to us, meaning people that have been exposed to Mpx and need assessment and screening and possibly vaccination.
Okay.
Thank you. Thank you, Darcy. Any more questions on your end?
I'm good, thank you.
Okay, thank you. And Kate Ryan, I believe you do have a follow-up question for the county executive.
I do actually, and this is health related because some of my non-health related things were answered previously. We are still asking Dr. Bridgers to stay on, if I have that right, correct? When and what's the situation on a permanent health officer? And I ask because our neighbors in the district also have acting currently. So it looks like your neighbor will also be looking for a health officer. How tough does that make it?
I guess if I don't know whether Dr. Bridgers wants to handle that, but I'll say we're looking at a different way of doing this in terms of what the requalifications of the health officer would be, and if we pursue that, that would make this process probably a tad easier.
Meaning that Dr. Bridgers could come on as health officer?
Kate, there's nothing acting about this position. All the individuals who are set in an interim response or an acting period have the experience and the wherewithal to maintain this position. So I will just stop there. I really haven't been focused on the process. There are multiple challenges that are currently we're responding to and maybe on the horizon, and that's my focus.
Understood.
It always was a team effort. There was never like one person who issued edicts and then everybody said yes. So we've always, and so the staff we have was very much a part of the effective work we did before. So nothing's changed in that regard.
Understood. But again, you're saying that you are looking at getting a change to the requirements so that that barrier to having someone else come in is removed, correct?
That is true. I mean, we turns out, none of us knew this, that Montgomery County, as is sometimes the case, had unique rules that nobody else was using. And so we're rethinking our rules.
Gotcha. And then lastly, is there any thought, or what is the situation with children coming into the school system? Will or are COVID shots, vaccinations required? And Dr. Bridgers, you said 9,000 out of 50,000 children. Is that 50,000 eligible children?
That's 50,000 based on the census data that we had from last year. That was under 5, Kate. And so we're having conversations with our MCPS partner and their newly hired medical officer. We began those discussions to look at the requirements, some of those requirements, those safeguards that we put in place during the break and during Omicron, such as, testing after scheduled breaks, testing to return after the summer, getting vaccinated, hosting clinics that are accessible for those individuals who are eligible. Those are some of the current measures in place, and there will be others that include not only vaccinations, but testing, but education as well.
But right now, there is no requirement that your kid cannot come to class if they are not vaccinated, correct?
There's current no requirement.
Thank you. I appreciate it. I know it seems sometimes like, are they listening to the answers? But we always like to be absolutely sure.
That's okay. There are currently no requirements, but that doesn't mean that there aren't requirements prior to school actually opening. We are going through the guidance now and looking at the guidance that's set forth, not only by CDC, who hasn't updated any K through 12 or child care recommendations, or the state, who recently drafted and presented some guidance. So we're looking at all that now, and we're shaping the guidance based on the data and lessons learned from the fall and last school year to make it more robust and earnest and keep our kids in school.
Understood. Thank you very much, everyone.
Thank you, Kate.
Thank you.
I do not see any more requests for questions from reporters, so we're going to wrap it up. Thank you, everybody, for joining us this afternoon. Thank you, Ms. Townsend, for joining us today. Have a wonderful afternoon. Stay safe. We'll see you next time.
Bye.
Bye.